Hi, my name is Dr. Chelsea Walton, and I'm a clinical psychologist here at the Wellness Center. And in honor of World Mental Health Day, we'll be presenting a bit on maternal mental health. This is actually part one of a two-part series on understanding maternal and infant mental health. And so this part of the presentation will be covering defining perinatal or maternal mental health rates, as well as common signs and the differences between perinatal mental illness and typical experiences during pregnancy and postpartum, what can be done to support this population, as well as what are some of the benefits and some of the outcomes of addressing perinatal mental illness. As mentioned, this is part one of a two-part series, and so the second presentation is on infant mental health, and that will be presented by Shannon Seymour, who's the director of the Wellness Center and also a psychologist at the Wellness Center, and she'll be providing a bit more information on the history of infant mental health, the key concepts and why infant mental health matters, what the role of caregivers is, as well as what can be done by healthcare and early childhood educators. And so if you find this presentation to be helpful and interesting, I would highly recommend that you view part two, which is on infant mental health, so that you can get a better understanding of how they fit together to inform the overall mental health and well-being of society and of individuals. And so I really like this roadmap because this helps to kind of illustrate how mental health is relevant at every stage throughout the lifespan. So the mental well-being of the mother during pregnancy will impact, how she does in the postpartum period, similar to the partner, to the father, as well as, in the postpartum period, the way that she functions, how that impacts the development and the well-being of the child. And if there are any concerns in those early periods, we definitely want to be able to identify and address them early on, so that we can have more resilient children and healthier adults. So what is perinatal mental health? So that just refers to an individual's state of mental and emotional well-being during pregnancy and the postpartum period. It's a little bit more of an inclusive definition because it does seek to include fathers and partners as well, not just the pregnant mom or the mom in postpartum period. However, for the purposes of this presentation, I'll be focusing a little bit closer on the well-being of the mother, since she tends to be impacted more directly by issues during pregnancy and postpartum, labor and delivery, and issues with, conception or infertility or pregnancy or infant loss. And so perinatal, that refers to the period between conception and through the 24 months after delivery. And prenatal or antenatal, where you hear that term, we're talking about during pregnancy. Postpartum or postnatal, we're really referring to those couple of years after giving birth. And so I actually just want to take a step back and just clarify that when we're talking about, who's directly impacted by some of the issues that can arise for childbearing families, I just want to be clear that fathers and partners can be directly impacted by pregnancy loss and infant loss. But in terms of some of the other concerns, such as, the impacts of the pregnancy itself, that is happening in that childbearing body. And so that is kind of why we tend to kind of focus in a bit more on the maternal mental health in this presentation. So a little brief history of perinatal maternal mental health. And so it really kind of picked up some awareness over the previous century and change. And so Dr. Hamilton was regarded as the 20th century father of postpartum psychiatric illness. He founded the Marseille Society, which sought to increase awareness and advocacy for research, treatment, and support of perinatal mental health issues. In 1987, Postpartum Support International was founded by Jane Honigman, and this was a global network that sought to increase resources and awareness related to mental health in childbearing families. And they also have a certification program in perinatal mental health for healthcare providers. So a lot of their work too helps to increase the knowledge and the skill set in healthcare providers who are working with childbearing families. And so through the 80s to the 90s, there was a significant increase in awareness and resources, and something that helped to kind of solidify postpartum mood conditions or postpartum mental illness was having the specifier of with postpartum onset included in the DSM-4, which is the Diagnostic and Statistical Manual of mental health disorders that is used by mental health professionals to help to diagnose issues in the individuals that we see. And so we can have a look at some of the rates of perinatal mental illness. So pre-COVID, the CDC estimated that 1 out of 8 women experience postpartum depression, which is, a pretty prevalent and pervasive concern. In the early stages of COVID, that increased to 1 out of 3 women actually screening positive for postpartum depression. And this is attributed to the stress of the COVID-19 lockdown, as well as reduction in support for childbearing women. So, not being able to maybe bring partners with them to appointments, not having support there during labor and delivery or in the postpartum period. The lockdown really kind of disrupted a lot of the ways that, childbearing individuals and families would receive support after having given birth. People were feeling pretty isolated and disconnected from, their families, their friends, their support, especially when they did not live, in close proximity and travel was required. And so that increase was, in part attributed to the isolation and kind of lockdown and social support. Another interesting statistic was that 1 out of 10 men in the U.S. Had screened for paternal depression. And so the strongest predictor of that was actually maternal depression. So if mom was struggling with postpartum depression, then it would increase the likelihood that dad would struggle with postpartum depression. And so these statistics help to highlight that these issues can impact anyone. They don't discriminate based on the gender, socioeconomic status, anything like that, right? And it's also a global experience as well, that, these rates are similar across the world. There's some concern that some of these difficulties in this population are actually underreported or maybe being underidentified. So in part that might be due to those who have more frequent contact. So healthcare providers specifically who have the most frequent contact with childbearing families, either not assessing for it or recognizing the signs that there is postpartum depression. And so in terms of it being identified in clinical settings, about 50% were determined to be identified with prenatal depression, and 31% of those who struggled were identified. And then those who received adequate treatment, those rates are even lower. So there, again, is kind of a disconnect between when we actually identify that individuals are struggling with depression in the perinatal period, that they're not all going on to then receive the support that they need. Okay, and so we'll get into understanding perinatal mental health issues a bit further in the coming slides. And so when we talk about perinatal mental illness, we're talking about mood and anxiety disorders, more specifically, and we can refer to them as PMADs for short. And so some of the difficulties that fall under this umbrella would be major depressive disorder, bipolar 1 and 2 disorder, generalized anxiety, and obsessive compulsive disorder. And so just a trigger warning, the next slides have mention of suicide and self-harm. And so if it is not something that you can tolerate at this time, or you're wanting to kind of ingest, then you're always welcome to skip past the next few minutes of this presentation and find a place that is helpful for you to pick up. Major depressive disorder is characterized by changes in mood, such that an individual presents as being sad, empty, or irritable, and then there are usually some physiological changes, some somatic changes, and changes in thought processes that accompany it. And so some of the criteria for this disorder include 5 or more of the following symptoms being present during a 2-week period. So depressed mood most of the days, more days than not, a loss of interest or pleasure in activities, significant unintentional weight loss or gain or appetite disturbance, sleep disturbance. So that might look like having difficulties falling asleep, staying asleep, or waking up early in the morning, or sleeping for kind of extended periods of time beyond kind of what is typical. Psychomotor changes, so being kind of restless or slowed movement, a lot of tiredness, fatigue, lethargy, low energy, feelings of worthlessness or excessive, inappropriate guilt, as well as difficulty with concentrating or decision making. There can also be thoughts of death or suicidal thoughts, thoughts about harming oneself or ending one's life, or attempts to do so, as well as self-harming behavior. So things like cutting or burning or pinching, behaviors like that to inflict self-harm. So in the perinatal population, this will often look like an individuals who's very overwhelmed, has lack of, positive feelings or connection to their baby, And that's kind of the one that would most indicate that, there is significant difficulty in terms of the individual's mental health. So that lack of connection with the baby, difficulty with caring for oneself or family, feeling of isolation, or withdrawing from the person's regular support, feeling agitated, irritable, having increased somatic symptoms, so a lot of aches and pains, GI problems without kind of like a known physiological or like medical reason. You might hear this person who's struggling with perinatal depression say things such as like, I just don't feel like myself, this isn't like me. So just really feeling disconnected from oneself as well can be a part of this depression. And so it can be a bit difficult to kind of differentiate, well, what is typical versus what's not, because with the hormonal changes that occur during pregnancy and postpartum, there may be a bit more moodiness or tearfulness. And so it can be helpful to know, okay, well, what is typical versus what might indicate that this person is struggling with depression. So in pregnancy, you can expect that the mom will be a bit more emotionally reactive, so maybe becomes tearful more easily, but generally their self-esteem is a bit more stable in terms of how they feel about themselves, their worthiness, their feelings of self-competence. Sleep disturbance is usually due to issues such as like heartburn or a frequent need to use the bathroom throughout the night, not usually to difficulty with, just kind of getting asleep or staying asleep outside of kind of that discomfort of being pregnant and changes in the body. Suicidal ideation isn't a typical part of pregnancy. Moms might tend to become tired more easily, right? Because there are a lot more demands on the body. But with rest, the energy levels will restore. There is, joy and anticipation present. So, feeling excited about the baby, about the pregnancy, about, what's to come, to meet the baby. And, even if there is worry present, which is very typical to have some worry present. And then appetite would be expected to increase, not decrease. In terms of depression in the pregnant person, that might look like a lot of the symptoms that we outlined in the previous slides. So that gloom, irritability, feeling agitated. It might also come out as being very angry, rageful, that low self-esteem, difficulty with sleeping, but not for the reasons that are typical of pregnancies, such as needing to use a bathroom a lot throughout the night or just kind of getting comfortable. Suicidal thoughts might be present, as well as difficulty with restoring energy. So, even when the individual does get rest, they might not feel that like they have more energy, like they had a restful rest, basically. Anhedonia, so just meaning that things that would normally bring them joy, or things that they would usually engage in that, were pleasurable, may no longer, bring forth those feelings. And then the appetite will tend to be dysregulated. So you might see that there's a decrease in appetite, or, appetite may be kind of up and down, and that's not due to any other kind of like medical illness that might occur during pregnancy. It's a part of the presentation of depression. And so The term baby blues may be something that you're familiar with, and have heard before, maybe have experienced if you've been pregnant, given birth before. And so what it is just a period of kind of tearfulness, kind of moodiness, mood swings, being a bit more reactive to external stimuli, and feeling exhausted following childbirth. So the mood of the mother is predominantly happy or content, and mom responds well to rest or engagement in an enjoyable activity or connection with others, so enjoying, having visitors, or, sharing pictures of the baby, things like that, could be expected during this period. And the self-esteem is generally unchanged. And this is caused by hormone fluctuation at the time of birth and that acute sleep deprivation that new parents often face. And it usually lasts between 2 days to 2 weeks after birth, and will peak in that first week following delivery, so between kind of 3 to 5 days after delivery. And so in terms of postpartum, and so in the next slides, I just want to give a trigger warning because they're referring to birth trauma, and pregnancy loss, and other kinds of situations or circumstances that might be potentially traumatic to childbearing families. And so again, if you need to hit a pause the presentation or skip past the next couple of slides, that is completely okay. So postpartum PTSD, this is referring to post-traumatic stress symptoms related to birth trauma. So this is an event that occurs during the labor and birth process that can involve actual or threatened serious injury or death to the mother or her infant, or the woman feeling stripped of her dignity. And so examples of this could be having an emergency C-section, postpartum hemorrhage, premature delivery, stillbirth, NICU admission, forceps, vacuum delivery, and so on. And so some of the symptoms of post-traumatic stress include avoidance. So that is, attempts to avoid any stimuli that remind the person that has experienced the trauma of the trauma. Intrusions that could look like, having dreams, intrusive thoughts or images about the traumatic event, negativity, so a change in ways of thinking that is a bit more on the negative side, so thinking that things, negative thoughts about the future or about themselves or about kind of the process, having difficulty kind of recognizing maybe the balance in the experience, and arousal, so kind of the feelings of always being on edge, or as though something may potentially happen, having difficulty relaxing or calming oneself. And so this quote is really grounding, and for clinicians and other healthcare providers when dealing with childbearing families, expectant mothers, or mothers who have given birth, that birth trauma lies in the eyes of the beholder. So mothers who perceived that their births were traumatic were often viewed as routine by clinicians. So some of the things that seem to be common, and can be easily overlooked as just kind of being routine, may in fact actually be quite traumatic, to the mother. And so it's important to recognize that just because it's common, or it's something that is seen in the day-to-day, or you've heard of it happening before, doesn't mean that it's not traumatic, that it's not stressful and not negatively impacting the person that it's occurring to, that mother. So we'll move on to perinatal anxiety. So anxiety is having excessive and difficult to control worry. And this can also be presented with other symptoms such as feeling agitated, irritable, restless or on edge, poor concentration, difficulty with racing thoughts, or mind might go blank, sleep disturbance. So again, kind of that difficulty with falling asleep or staying asleep or waking early because of the fears or the worries that the individual has. And then somatic symptoms as well. So things like aches, pains, digestive issues, those are fairly common with anxiety. And so what is interesting is that anxiety rates are estimated to be fairly similar between moms and dads, showing that the dad has the same kind of risk of experiencing prenatal and postpartum anxiety, may share similar worries or fears as the mom as well. Some other perinatal mood and anxiety disorders include postpartum OCD. So this includes intrusive or repetitive thoughts or images of harm coming to the baby. And so a lot of times this will present as fears that, mom will, she'll do something to deliberately harm her baby, or accidentally harm her baby, like dropping baby, or, fears of contamination. So, in terms of like germs, or, baby becoming very sick. Other parts of that presentation include that there is usually some compulsive behavior. So a lot of times it might look like excessive like organizing or cleaning or rearranging. There may be other rituals or avoidance of, behaviors that help to take care of the baby for fear that they might do something to harm the baby in the process. And so with postpartum OCD, the thoughts can be very frightening, and very, concerning and disturbing, distressing, everything, right? But usually there's a really low risk of harm to baby because there is that anxiety there, and the awareness of, what is happening, what could happen to baby, being really distressing and something that they would absolutely want to avoid at all costs, right? And so that really means that the likelihood of them doing something to actually harm the baby is incredibly low. In terms of postpartum psychosis, the parent might have thoughts about the baby, or things happening to the baby that we might recognize as being concerning, or other people might be distressed when they think about something similar occurring, but they don't necessarily recognize that those thoughts are unhealthy. So there may be less anxiety about the thought, or the behavior that they're doing. They might have limited insight about the way that, their thoughts are distorted. And so in this instance, this parent would be at a greater risk of harm to the baby. So sometimes this looks like, a parent thinking that, their baby is possessed or something like that, and that there's some action that they need to take to save their baby from, possession or damnation. And so in these cases, parent is usually at a higher risk of harm to baby because they don't recognize their thoughts as being unhealthy. And so this is where it's really helpful then for support systems to recognize that, mom, dad, or baby might not be safe in this situation, and to kind of get involved and intervene and provide support and get the parents the support that they need. And so in the previous slide, we briefly kind of went over postpartum OCD. And so, further to that, it's really that spiral of what ifs that the parent gets caught in. And perinatal women are at greater risk, 2 times greater risk for OCD than the general population. So that's a significant difference. And again, it's severely distressing. Depression is also usually a part of the presentation with OCD. Having OCD makes it really difficult for moms, new parents to enjoy their baby and to be attached to their baby. So this illustration here that was taken from the Postpartum Stress Center site helps to kind of illustrate, the ways that a parent might be presenting as, everything is okay, or, we're assuming that they're having an easy time, but internally could be struggling with a lot of distressing thoughts. And so in the illustration, it looks like maybe the mom's mom or the grandparent to the baby is saying, "Don't you think this is the best time of your life?" And the mother is responding by saying, "Of course," but the thought bubble says, "I think my baby would be better off with another mother. I think I made a huge mistake. I think I will find my baby dead in her crib. I think my baby will fly out of her car seat and into a ditch. I think I will drop my baby onto the cement when I'm going down the stairs. I think I'm unfit to be a mother." And so those are really painful thoughts to have as a mom and as a parent. And it's really important for us to be able to provide support. And, if someone is dealing with having these difficult thoughts, to be able to, respond to them and connect them to resources that could be helpful, as well as recognizing that other people struggle with these thoughts as well. And part of kind of what will maintain these difficulties is that if moms express having thoughts like this, then, other people will become alarmed, right? But sometimes the alarm is kind of misdirected. It's thinking that, that maybe the mom is unfit because they have these thoughts. But that's not necessarily where the alarm needs to be directed. It's more so towards the well-being of the mother and the distress that she's dealing with. And so for a parent that is experiencing these thoughts, there are a lot of worries and fears usually that if they share what's going on internally, in terms of some of the distressing thoughts that they're having, that, the baby will be taken away from them. So in terms of what puts individuals at risk for developing a perinatal mood or anxiety disorder, that would include a family history or previous personal history. So, if they'd experienced a perinatal mental illness with a previous pregnancy, that increases the risk that they might experience it again. A personal history of depression, anxiety, OCD, bipolar, eating disorder, other mental illness puts them at risk for experiencing that during the perinatal period. Significant mood reactions to hormonal changes, a history of childhood abuse, endocrine dysfunction, the number of children that a family has. And so sometimes then, having other children and having a newborn, that's a significant increase in demand and stress to the parent because they have a lot of different individuals to account for and needs that they're trying to juggle. And then ability to function in general life, work, and in relationships, education level as well can be a risk factor. Some of the social risk factors for PMADs include not having adequate social support, being a single parent, struggling with being in an interpersonal, a domestic violence situation or an abusive relationship, other relationship stressors, financial stress, poverty, the stress of childcare, loss or grief, and then also barriers to care. So not having access to the supports that they need, or to resources that maybe some other more privileged families might have. And so for the partners, the risk factors that they may develop a perinatal mood or anxiety and disorder would be feeling burdened or trapped in the relationship, or by having a child, the financial responsibility. So for partners, especially dads, male partners, feeling that they have to earn to provide, those stressors can contribute to the likelihood that they'll develop mood or anxiety disorder. Feeling outside of the circle of attention. So a lot of times the attention goes on, baby, and then kind of expands out to mom, and then dad sometimes is kind of just on the side, not really receiving, I guess, the same level of attention or care or support that baby and mom might. Sleep deprivation, feeling isolated or lonely, and so especially for partners who, the mom, female partner is, a main source of support for them, or a main source of support for them, or like they were their best friend before. When baby kind of is born, comes into the picture, they require a lot of attention and a lot of effort to be cared for, and so that can take some of the attention and time away from the relationship. Missing the sexual aspect of the relationship and intimacy in that way is also a risk factor for partners. some of the factors that can help to exacerbate a mood or anxiety disorder. So if there's already one present, these are the things that can make it more difficult to recover from. So that's the lack of sleep, physical pain or inflammation, unresolved grief or loss, a complicated relationship with own parents, so having to deal with, the triggers that might arise from becoming a parent, not having enough sleep to feel as well as you could be. Lack of sleep, it can be a major trigger for mood or anxiety disorders. Any complications during pregnancy, birth, or breastfeeding, again, this is another stressor, and that is a significant contributor to mental health issues, health conditions in the parent or in the baby, as well as the temperament of the baby. So, sometimes the parent's temperament and the baby's temperament don't quite match up, and so it can be a bit more demanding for parents then to meet needs of the baby, especially when their needs are quite different. Other age-related stressors, so things such as being a young parent, a teen parent, or being in perimenopause. And one that is often a source of stress for women in general, but for moms as well, would be superwoman syndrome. So feeling like they have to do everything, and everything that they're doing has to be done excellently. That is another stressor that can contribute to mood disorders, anxiety disorders worsening. And so this is just a statement on social support from the Postpartum Support International that really highlights how important social support is to families during pregnancy and the postpartum period. It's a critical part of the wellness of moms, dads, and the infant. And so there is help available for those that are interested and or feel like they might benefit from receiving some mental health support. If they've identified, maybe through this presentation or otherwise, that they may be struggling with, postpartum depression or anxiety, then reaching out to a mental health professional to establish a relationship could prove to be pretty beneficial. And some of the things that usually come up as part of the focus of mental health treatment include changes in identity, grief and loss, expectation versus reality, working on reducing comparison and perfectionism, communication, conflict resolution, anger management, increased support, and referrals for connection. And so overall mental health treatment will look at trying to address, what is going on within the individual that is potentially, exacerbating issues with anxiety or with mood, as well as, what can be done socially to get as individuals some support that they need, increasing skills and tools, and processing previous experiences as well that they feel might be a bit of a cloud over their pregnancy or, their transition into parenthood. So there are a number of evidence-based treatment models for perinatal mood and anxiety disorders. So one is cognitive behavioral therapy, and it's been shown to be pretty effective for prevention and treatment of depression and anxiety. Specifically, there's interpersonal therapy, which is shown to be effective for postpartum depression, more specifically. And then there are other forms of parent-infant therapy and psychoeducation, as well as groups. So some of the outcomes of addressing these mental health concerns in this population would include increased attachment security. It frees up kind of the bandwidth for parent and child to become more attached, parent to become more attuned and in sync with their child. Parents are better at reading their toddlers' temperaments and kind of understanding what their needs are. Improved parenting, so less likely to be punitive as well, which can exacerbate negative behavior in the child, leading to, more behavioral concerns for the child later on, which then makes it a bit more difficult to parent a child that has, a lot of challenging behavior. It can be a bit more stressful. So the way that, parent is feeling and is functioning emotionally and mentally impacts the way that, their child behaves, which also then feeds back into the way, parent feels about their relationship with their child and as a parent. And so it really benefits parents and child and parents again and society at whole when these conditions are addressed early on. And so in order for a child to be happy and healthy, it's important that their parents' health is optimized. And so that is one of the key kind of takeaways from this presentation is, that focusing on oneself as a parent doesn't take away from the child. It tends to make you a bit more of a adept parent and to feel more regulated and skilled in addressing the needs of your child. And so for a bit more information on, attachment and understanding, infant mental health and how maternal or parental mental health feeds into infant mental health, I'd highly recommend that you view part 2 of this presentation. As I mentioned, is presented by Shannon Seymour, Director of the Wellness Center, as well as a psychologist and an expert in infant and child mental health. And I just request that you take a couple of minutes to provide some feedback on this presentation. Thank you for viewing, and if you have any questions, you're welcome to reach out to us at the Wellness Center.